I'm just going to make two comments about trial, because ibrutinib has become, you talked about a lot, you talked about the other drugs. Recently if you go to our website, patientpower.info or patientpower.eu, I interviewed two patients on ibrutinib. Both were very sick. One is doing great. One, since the interview, passed on because did have that transformation. And I was doing interviews with a guy named Randy Shirley, who was one of the two patients who died on ABT. And we were interviewing him and following him through the trial, and then he had this tumor lysis. So you have to go in all this, the trials, with your eyes open, right? So that's the important discussion. Very exciting. Can I get tomorrow's medicine today? Is it right for you? Can you qualify? Can you travel across the country? Or some of you have seen Dr. Brian Kaufman, who does a blog from the US. He's from California. He went to John Bird in Ohio, 3,000 miles to get ibrutinib after many previous therapies were no longer working. So there are a lot of questions for you and your consultant, as you say, related to trials. Okay, here's a question that is sort of more general. Dr. Follows, is there an increase in CLL? And if so, why?
So that's an often asked question. There is an increase in testing and an increase of finding CLL, undoubtedly, because we do more blood tests nowadays. So does that actually mean a true increase in incidence? There's an increase in prevalence because patients who died previously or would have had 2 lines of therapy and then would have been moved into a palliative situation are no longer having their treatment shortened like that, so are more likely to be alive after a number of lines of therapies. So our clinics are bigger. So there is that perception that there's a lot more CLL around. But I don't know whether the actual true incidence of new cases of CLL has changed.
Okay. Gwyn, if you're in a clinical trial, do you get better care?
So I think it may feel different because in some ways you may have a greater requirement for visits up and down to the hospital. So in some ways you may be seeing your clinician more regularly, seeing the trials team, having sort of more regular monitoring, but in some ways that dictated by the needs of the trial. I don't think that disadvantages, patients who aren't on trial. I think it's more dictated by the requirements of the trial in terms of the monitoring, and I'd like to hope that the standards of care for the patients, whether you're on trial or off trial, are as good as we can provide.
Okay, and then this goes back to what we were talking about earlier. With any of those drugs that you mentioned, it sounds like if they've had FCR or BR or even more than once, they still might be able to qualify for one of these trials if it's open.
Oh, absolutely. So trial inclusion, exclusion is just simply very variable between trials. I mean, a good example was the Resonate trial, which permitted patients who had previous allograft. Now, those of you in the know realise that prior allogeneic transplant has been a block excluder from trials, and it's actually influenced some of my discussions with patients before, because they say, well, what happens if my leukemia comes back? Well, actually, it might compromise trial entry. And a real story about this, when I was up in Yorkshire giving a talk a year or so ago, and I was sitting there, Pete Hillman was giving his talk, and he just flashed up the inclusion, exclusion, and I hadn't clocked that actually allogeneic trial was a permitted indication. And I sort of making conversation afterwards, no one was asking any questions. I said, was that right? And as a direct result of that, one of my patients, who I thought I could not get on that trial, got ibrutinib. So there you go.
I have just a basic question. You're our barometers for our future, okay? You've used the word exciting, you've shown a lot of slides, but in your career now, how upbeat are you for us? For each of you, I'd ask, why don't you go first? How upbeat are you? You've seen hundreds and hundreds of patients.
Yeah, no, I think so. I think, having been in my role for 10 years, doing lymphoma, CLL, and, I can't recall a time when in some ways there just seems to be so many new developments, so much excitement or whatever. So I would say, every reason to be upbeat.
And I would say the same. So I came to Cambridge in 2004 and started initially with the CLL lead and then took the lymphoma lead in 2007. And I would say the last 3 years have the whole mood and atmosphere in CLL has completely changed. We've gone from discussing campath and depths of remission and antifungal therapies and how you manage complications and who, the complexities of transplant, and suddenly it's like being in the sweet shop with all of the things. Oh gosh, are we going to select that one and take that one? Now, of course, we're far from actually being able to do that in the clinic, but I think just being able to have this potential of these options is a great, exciting place to be.
So you mentioned ibrutinib and idelalisib and ABT. So at some point, maybe, and in trials now, but at some point you may have a choice, please God. Somebody will be sitting here. How will you choose?
That is a great question, because you may find idelalisib rituximab gets a license on approval, and you may find ibrutinib, idelalisib rituximab are going to be side-by-side competitors. And you may be influenced by things like, are they on warfarin, which is a bit of an issue with ibrutinib that we haven't talked about. You may be influenced by the side effect profile. Idelalisib perhaps causes a bit more diarrhea. Is that something you move away from? You might be influenced by their genetic status. I mean, as you've seen, some of the 17p deleted data with idelalisib is fantastic. We may get more feel of things like Richter's as time goes on, comparing the two drugs. These are all open questions, and I don't want to sound that I'm pushing CLL specialists, but as the world gets more and more complicated, it might encourage non-CLL specialist clinicians to refer on, and it might encourage patients to actually find people who do CLL more of their full-time job. Sound like I'm advertising there, but
it's a lot more complicated than it was.
It's tremendously complicated, but great with it.
Yeah, if we could get a microphone over to her.
Hello, thank you very much. My question is about infections. FCR, your immune system severely suppressed afterwards, probably for quite some considerable time. With these new small molecules, what sort of infections are patients getting, or is that actually not an issue any longer because the immune system's been more supported?
So that has been debated a lot, because the serious infection rates in the trials was actually pushing 25%. But you heard me say that these are really heavily beaten up patients going into those early phase trials. It's going to be fascinating to see as a more mature data set comes through from less heavily treated patients, whether that infection rate stays. Because the suggestion is when patients have been on therapy and they're in remission, their rate and incidence of infection seems to fall, i.e. suggesting that the immune system's recovering. But we must remember all of these drugs are inhibiting a key part of immune signaling. And if you think how Bruton kinase was originally described, it's with a severe immunodeficiency syndrome. So if you are born with an inherited deficiency of that enzyme, you have a really deficient immune system. So these are open questions. Over 5 years, will the immune system then start to fail if you've been on continuous therapy? We hope not and suspect not, but we don't know.
So that's, some people know there was a drug, in the 50s or 60s, thalidomide, and then it caused all sorts of problems, birth defects, etc. If you switch off something in Mother Nature's immune system, is there a bad shoe that drops later? And you're saying you don't know.
I think we've always got to remember that when an enzyme or a protein is inhibited is absolutely critical. So switched off in utero when your blood system is developing could be very different from switched off when you have an established blood system. And we know that from so much knockout mouse modelling, that you can knock out proteins in developing mice. If you knock them out really early on, they don't create blood. But if you knock them out at, say, day 14.5, day 15 of embryogenesis, they then can make blood and there's no apparent defect. A great example is the AML1 protein. So we know that you need key enzymes and proteins at different phases of development that you might not be as dependent on. And BTK has to be an example of that, because we've inhibited it in all these hundreds of patients around the world, and we're not seeing huge readout of problems at the moment.
Thank you. What about the cost of the IBA? What was it called?
Ibrutinib?
Ibrutinib, yes. Is it likely to come down?
So you're going to get me on capitalism and market forces again. So one of the problems I have as a true capitalist is that market forces are not allowed to apply to the pharmaceutical industry because we create these ring fences of legislation, which is fine because you want to make sure you have proper ibrutinib, not ibrutinib made in a factory without quality controls. But it means there isn't natural competition in the marketplace. And if your healthcare insurers in the States, and I'm looking at Andrew, not that he's responsible for it, but if they pay the price, if in the States they will pay $100,000, why would ibrutinib's competitor come in at $30,000? Because there's also this slight thing that if you come in with a really cheap drug, I think, is there a problem with that drug? Are you trying to push it into the marketplace because it's not very good? And these, I've heard all of these debates at conferences, so it's not a true marketplace. To say ibrutinib will come down in price is hoping, I think, but I don't know whether Andrew has views on that.
Well, I'll just say that, we didn't really talk about this much, but I was one of the early patients in FCR. I developed years later at long remission, and I don't think I would have survived had I not been in the FCR trial. So I'm very appreciative of rituximab being developed. Worked for me. But I developed a second cancer, myelofibrosis, scarring in my bone marrow. Thank God there's a drug that treats at least the symptoms and maybe the underlying conditions. So I don't have any symptoms, but how much is the drug? In dollars, $8,000 a month. A little white pill in the morning, little white pill at night. Is it worth it? I mean, I think it is, and thank God insurance pays for it. But those are going to be the questions, is what's affordable. And I would just mention, and this will relate to advocacy, what we talk about later, Dr. Kantarjian from MD Anderson wrote in New England Journal about can the drugs become less expensive over time? So if somebody here is on ibrutinib, year 1, year 2, year 3, the drug company makes a lot of money back and then some. But if we are on it for many years, can they still justify charging so much?
And you stray into this UK-specific territory of NICE and their behind-the-scenes deals that don't become publicly known. And so lenalidomide is a good example where after 2 years of therapy, if a patient with myeloma stays on therapy, then there are aspects of payback from the company. And I'm sure all of these are going to be discussions that will be had.
I had CLL for 10 years before I had my first treatment, or my only treatment, which was FCRM, which finished 2 years ago, and I'm fine now. The haematologist I see at my general hospital is very pleasant, but isn't a CLL specialist. I've no idea where I'm going to go from this 2 years. I would like to see a CLL specialist. Should I try to see one now at this stage, or do I wait till for however long and then try and see somebody? What route should I take?
Well, these are very good questions, which I get asked by colleagues and patients. What I tend to say is I will see somebody in Cambridge as an example, and then I say, well, look, I will see you and discharge you, ask your GP to refer you back in 2 or 3 years even, because you can't, our system won't allow me to book a 3-year follow-up, or contact us if something changes. Because I think touching base, having a discussion can be very useful for patients. But, FCR, mitoxantrone, the data's great. These remissions could last years. Is it worth, what's your net gain travelling further to a specialist centre versus review locally? But I always encourage local dialogue with clinicians, and the vast majority of UK clinicians, if a patient says, look, you understand where I'm coming from, I'm really actually quite into my disease, I've read a lot about it, and I'd like to discuss with the CLL expert in our local teaching centre, would you mind? Most people will refer on.
That probably would be the best way to go then, to talk to the consultant that you see.
I just want to ask a quick question to Gwyn. So people are drinking from the fire hose today. They're hearing everything, ABT, ibrutinib, all the different cells. It can be crazy making and anxiety producing. What advice do you give people to put things in perspective so they live their life?
Yeah, no, I think that's a very fair comment, and I think, you know, in some ways sometimes you can perhaps see that when people are coming up, you know, for their next clinic review, and, you know, people will sort of say, oh, you know, I've had a week of, you know, anxiety, thinking, well, I'm coming back to clinic, has anything changed? And, you know, everything sort of comes back to the fore again. But I guess that's it. I guess what we want to encourage is that, you know, we know it's a chronic condition and trying to live alongside that, and that, you know, if people are well, in remission, you know, if there's mechanisms for trying to sort of put that more on the back burner, and just reassuring people that obviously, you know, if things are changing or whatever, they know that they always have a focus of contact and can make, you know, ready access to us. But in some ways it is trying to sort of, you know, keep that sort of perspective that actually we want people to be able to sort of get out there and be able to enjoy and live the quality things. But of course, partly it's people's mindsets in terms of, yeah, how can you compartmentalise things?
And what about seeking guidance for depression or anxiety clinically?
Yeah, no, I think, again, I think sometimes recognising that, because I think sometimes patients sort of say, well, you know, I don't know that I should necessarily be feeling like this. And sometimes you'll get people who are in remission and maybe have been in remission for some time, and then it perhaps takes them by surprise that actually they're low in mood and whatever. So I think sometimes from our perspective, recognising and allowing people that actually, you know, it can be an emotional roller coaster, and sometimes these feelings don't come to the fore until some time after. So, and getting people to seek help so that in some ways they don't feel that in some ways they're having to struggle alone. You know, you sort of think many people can suffer anxiety, depression, and then sometimes having other factors where you're living alongside chronic illness or chronic condition with uncertainty. So I think it's recognising that that can happen and advising me that it's really is okay to seek help.
And the spouse perhaps as well.
Yeah, absolutely. And it might be sometimes that it's the spouse that's sort of flagging, well, actually, maybe they're not doing so great, and that, you know, they're low in mood, and what can I do to help?
I think you touched on one thing I'd like to say is
Sure.
that it's almost a post-traumatic stress reaction. We see actually quite a few people complete their chemo program. Those who want marrows and CT scans, you know, if they want them, we do it. We say, great result, fantastic. Look, your bloods are fine. 3 months blood check with the GP, I'll see you in 6 months. And then they ring Gwyn about 3 or 4 weeks later, and they've gone through this real mood collapse. And that is actually well recognised in oncology, more so in younger patients, isn't it? That being really psyched up, treatments, bang, 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 bang. You see your consultant says, fantastic, off you go, see you 6 months. And
I think we've noticed that more, and maybe our awareness is better, that quite often now when we've got patients who are at that point in time, I often sort of say to them, this is what can happen a little bit further, so that in some ways people can recognise that and then get some help.
My wife and I, when I was diagnosed, I thought I was dead. I was younger than many of you, but some are younger. I was 45, so I thought I was dead. I didn't understand the difference that you explained between acute leukemias and chronic. My wife was very depressed. We sought a counselor, and that made a huge difference. We got education to understand what CLL was. I had no treatment for 4.5 years. I connected with other patients that connected me with a CLL specialist that led to a clinical trial, and we got our heads on straight so we could live our lives. So that was our approach, but I would recommend it to others.
It was just a question about trials. If you are on a trial, if you elect to go on a trial, or are put on one, and the side effects are really bad, I mean, I know you can't avoid side effects, but are you contracted in to staying with a trial in some way?
Absolutely, categorically not. So these are enshrined actually in international health law, if you like, the rights of clinical trials participants. So even a second after you signed the form, or after you've had all your investigation, you can pull out. You could have all of your scans work up and decide, fantastic, I've had a good workup of scans of every part of my body. I now withdraw. You can withdraw at any time.
But the trials but if you're remaining and you can get through it, they want to know everything too, because that informs everybody else.
Yes, yeah. Particularly if you come off trial. So one of my idalastilib patients who came off because of colitis, which is unfortunately a recognised late-onset colitis with idalastilib. They're because she didn't come off because of progressive disease. That particular patient has been followed very closely because we can get more information from them. They don't have to, and the patient's very keen, but you are likely to be, if you come off trial, you're likely still to be followed.
14 years ago, I was in the FCR phase 2 trial, right? And I wanted to stop after 3 cycles of it. I had terrible nausea, et cetera. And Alice, who was the nurse, Alice Lynn, said, we really need you to go forward if you can, because it's for 6 cycles, and we need the understanding of what a difference it makes. Because my counts had gone down, quite well. And I said, okay, I'll push through. And then, of course, FCR became a world standard, not just because of me, but a lot of people. But so there is some responsibility of the trial if you can. And we manage the nausea.
I always wondered how the MD Anderson got median of 6 cycles, and somebody called Alice.
Alice she gave me a big hug.
I was just wondering, there seems to be a lot of exclusion of early disease. Is that the same with all these new drugs? Have they tried, the new drugs with early stage disease? And
So that,
in particular, you talk about tumour lysis. Sure, that would be less.
yeah.
Be better early on, rather than leave it till the tumours are so large that.
So these are big questions. Are you, with these different drugs that don't kill in the way of chemotherapy, should we be actually trialling them? So should we take early patients and randomise them? And actually what we're doing, or what is being done by international trial groups, is to take early patients with poor prognostic markers. So unmutated, 17p deleted, CD38 positive, that type of thing, and say, well, look, statistically, we know they're more likely to be on therapy within a year or 2 anyway. So that is a great population to see whether they would benefit from earlier use of these drugs. But just always remember the other side of the coin, what I said to you about ibrutinib and resistance. You've heard people giving their stories how they're 10 years before treatment. Maybe would their leukemia have been better, been exposed to a drug for 10 years? Or would it remove the use of ibrutinib in the future if you've developed resistance to it? And so these really are difficult questions.
The good news is we're all on a journey together with CLL that's accelerating and quite positive. But it just asks more questions. One point I'd make, we're going to take a break, is you will see clips from some other British CLL specialists at the end of the meeting that were shot last week at the European Hematology Association, where more data came out about ABT and idelalisib. You'll hear these videos will be posted online very shortly. And so you'll be able to be kept informed of what doctors are hearing. And that's a dialogue for you with your specialist. Okay, we're going to take a break? Okay, tea time.